And so I appreciate everyone's patience. And then we've been restructuring a little bit. As everyone may or may not remember, this is a collaborative effort with the Journal of Neuro-Oncology and Lenox Hill Hospital, where we really try to promote recent publications, and we look at the rationale, the results, and the relevance of the author's publication and what their findings are, which I find is always useful to talk to the author, and get their pick their brain a little bit. A few new faces. Ashley Rosenberg is joining us. She's going to be covering for Nitesh Patel for a while, really from an administrative standpoint. And I thank her for that. She's been a pivotal part of the Brain Turns experience and running the background of that. And so I'm delighted to have her helping out for the short term. And we'll try to get someone to cover for Dr. Patel as necessary. He's doing his fellowship down in Miami. And I'm pleased today to invite Dr. Michael Castro. We had to reschedule him from a previous meeting, but he's here to discuss a recent paper in the Journal of Neuro-Oncology that I found fascinating. And, Michael, I'll let you introduce yourself and kind of give us a rundown on what you're going to talk about. Appreciate you being here.
Sure, it's a pleasure. I really love having the invitation. So thank you very much, Randy. These are my scope of activities. I've been a medical oncologist most of my career and came to neuro-oncology in the last 5 years as a consequence of some special patients. I'm fortunate to be able to do this concierge molecular oncology consultations for patients. And then I have a 1.5 job as a chief medical officer at Cellworks, which was primarily involved in the biosimulations that I'm going to show you. And I now advertise that my academic affiliations are none, because that gives me a certain autonomy to do, out of the box and off-label things in private practice that are not possible in most institutions. And so it's with that, we'll get into the talk. Temozolomide, as you know, is the first and only cytotoxic drug that has a biomarker of efficacy. But not everybody responds to temozolomide. And on the other hand, some patients really have outstanding responses. And so the question is, we have MGMT methylation, but what else is there? And if you look at the fate of a drug, whether it gets into a cell, whether it hits its targets, is it metabolized intracellularly? Is it effluxed by drug resistance pumps? Then there's DNA damage repair and oxidative stress resistance, apoptosis blockade. And so in the end, there's a whole elaborate list of mechanisms that impact whether or not chemotherapy works. And if you do a survey of the literature, you'll find for temozolomide alone, we have quite a number of things to consider, including mismatch repair deficiency, the NF-kappa B and hedgehog pathways, and also things that enhance responsiveness, like DNA repair deficits and checkpoint repair deficits. And so one wants to think about integrating this detailed genomic information to understand whether the patient really has a chance of succeeding or not. And when you get into the details of the signaling pathways, you get a list that looks something like this. And I think of these as the sort of molecular anatomy of what determines temozolomide's efficacy. And I use this analogy of anatomy because, a surgeon wouldn't be able to get very good outcomes without, really being totally into the anatomy. And I think in medical oncology, for most of my career, we really haven't known any of this stuff. But now it's really possible to know intimately exactly what's going on in the cancer. And I think that can enhance our treatment decisions.
It also looks very complicated compared to the regular anatomy.
Yeah, but no one bleeds, though.
Yeah, that's the difference.
When you get a genomic report, there's nothing that's spurting at you. So in any case, if you consider a patient, let's say this is a patient who's got MGMT silencing, but who also happens to have MLH1 mutation. This is a situation that's not really that unusual, but it's going to impact what happens. And the reason why is because fetal mismatch repair is essential for temozolomide to have efficacy. And so when you knock this out, you're going to have a problem. So in this case, this patient already has some low level of DNA damage. And then when you add temozolomide to cause these familiar DNA problems like methylating guanine here and adenine at the N3 and guanine again at N7, then you need this fetal repair in order to get the single-stranded breaks that causes response. But without that, you get no apoptosis and treatment failure. On the other hand, you get a different form of DNA damage from chloroethylation of O6 that does not require mismatch repair. And in this situation, you can propagate down through the DNA damage pathway and trigger apoptosis. And so this is the situation of a patient who does not respond to temozolomide, but who does respond to LOMUSTINE in spite of the MGMT methylation. And so the idea is, can we take all of those pathways I showed you and put them together to come up with an understanding of what happens with a drug? And CellWorks has come up with this computational biological modeling where they take protein-protein interaction using Michaelis-Menten kinetics to create an avatar of the tumor in silico. And essentially what they're doing is taking signaling pathways that are responsible for the malignant hallmarks related to growth factor signaling and cell cycle dysregulation, really the whole list as it's listed on the slide here, to create this model of a tumor. And so far they have 3,765 genes, more than 29,000 interactions between their proteins. And that includes 286 kinases, 379 transcription factors, and 115 pathways to really try and provide this coverage of what's happening in the kinome and the transcriptome, and especially with DNA repair. And the output of this model are these efficacy scores that really represent what happens to the composite tumor phenotype when you give a drug. And it's on a scale of 0 to 100. We think higher scores produce better anti-tumor responses. They use 30 as the cutoff for response. And it is possible to go below 0 if the drug is having a deleterious impact that accelerates some aspect of the malignant phenotype. Now, as many of you know, temozolomide doesn't work very well in patients with the most common aberration in glioblastoma, which is EGFR amplification. And the reasons for that is because EGFR does a lot of bad things. It blocks apoptosis, it enhances survival, which is directly involved with drug resistance. So even though you damage the cell, it won't die. It grows back quickly while you're waiting for the bone marrow to recover. It upregulates DNA repair, and it causes drug efflux. And so if you imagine that we could take all of those pathways and integrate them into the results of drug simulation, we can come up with a much better prediction of what's going on with temozolomide. Now, if there's any radiation oncologists in the audience, you'd be happy to know that we can do the same thing with predicting radiation efficacy. And so the question is, does this really work? And I want to show you some of the background literature. This is Brian Alexander's work from the Dana-Farber, where he has 98 patients who had genomic profiling. They were biosimulated at CellWorks, and they merely separated around the mean high efficacy versus low efficacy. And they have these survival curves for radiation prediction, which are basically nearly twice as long for patients who were predicted to be good responders versus poor responders. And in their study, temozolomide efficacy also was associated with longer survival. Patrick Wen has also been interested in this. and at ASCO a couple of months ago, presented an abstract on 100 patients who are from the TCGA, and their information was downloaded. And then we looked at all of these different treatments in a biosimulation setting. And once again, they were able to show that for patients who were predicted to be high responders, they had a better survival. Now, the skeptics in the audience will notice that this does not really separate out prognostic versus predictive, because the data set is not randomized. And so that's why people are very concerned about whether or not this is really valid for predicting drug responsiveness. And so the prospective trial is pending. However, this is the sort of interesting thing that we see, that the efficacy scale on the, along the x-axis here shows that for a particular patient, different GBM therapies have different degree of success. And what I find so fascinating is that if you take a different patient, the therapies may line up completely differently, so that it matters actually what you choose for a patient in terms of their outcome. And here, 25 points on the x-axis equals a death reduction of 29% and a progression reduction of 23%. So it kind of mirrors what we already know from treating patients, that the utility of any particular treatment strategy varies in the population. This is really the laboratory and biosimulation equivalent of something we already know very well. And so we wanted to apply this to this controversy about how to manage methylated GBM. Do we give single agent TMZ, or based on the Nordic Group's combination trial, should we be giving this combination? And they reported a 16.7-month improvement in median survival for the combination. That is really, in oncology, an amazing thing. You know, we have in colon cancer drugs that are approved based on 1.4-month improvement in median survival. On the other hand, this combination is very seldom given. And the reasons why, you know, if you sit through tumor board, you know, you'll hear people say that the patient really isn't eligible, they're too old or too sick. I think there's a great concern that more than half of the patients need a dose reduction or can't complete the therapy. And these are people, you know, you may be taking through platelet transfusions or putting on growth factors. And then the nihilists also point out that the survival curves eventually come together. Well, that's true of all of us and for all cancers. But, you know, I think that this idea that progression-free survival is not important is something that I don't necessarily agree with. And so I remain interested in this. And so decided to dig into the TCGA to see what would the biosimulation say about these patients. So, and about these therapies. So essentially, we downloaded the genomics of 207 newly diagnosed patients, and we biosimulated them, and we came up with this interesting plot. Now, each point represents a single patient in terms of how they're responding to temozolomide and how they're responding to LOMUSTINE. And you can see that there is a diagonal which represents therapeutic equivalence. To the right of the diagonal means temozolomide's better. To the left means LOMUSTINE is better. And there's about a 4-fold difference between the best responding patients and the worst responding patients for both drugs. And there's no bell curve, meaning that this is relatively unpredictable. Interestingly, there are some patients over here who have a deleterious response. These are patients who have microsatellite instability. These patients also have some degree of mismatch repair, which doesn't quite make MSI. Nevertheless, it interferes with their response. And what's interesting is how well they do on LOMUSTINE compared to temozolomide. Some patients do have a better response to temozolomide, but most of the dots are on the top side of this line, which is kind of interesting because maybe lomustine is a better drug in the adjuvant setting. Interestingly, that was never tested in neuro-oncology, so there is no clinical trial that addresses that. PCV was tested once, but nobody did it with any idea about MGMT methylation, so we really don't know. Now here's the key question. Does the combination do better? In general, everybody's to the right of this line, so that was the central conclusion of the NOAA-9 investigators. But it's a little bit more complicated. Some people do really well. Here's a group that's at 100% efficacy. On the other hand, there's another group where there's virtually no difference between temozolomide alone and the combination. And then there's these people here who are not doing very well with TMZ, who really get a huge boost from temozolomide. And then there's a group of people who are sort of in between. They're already doing very well with temozolomide, or you can really wonder if this distance here from the diagonal is great enough to justify the extra toxicity. You can also ask the question the other way. What about comparing the combination to lomustine alone? And when we did this, there was this shocking discovery that there are some patients where there appears to be worse if you give them temozolomide on top of lomustine. There are 15% of the group is on this side of the diagonal. And again, we see these lucky 100%ers there, the ones who are not very much different, these people who get the synergy, and then again, the ones in between who you'd scruple a lot about whether or not you really need to do this treatment. And so what we find is that there are these interesting subsets. And those for whom the standard of care is already doing very well, and you don't add very much to by adding lomustine. On the other hand, there are some people for whom you get real synergy from the combination and not really great scores from the drugs individually. Then there's a group for whom lomustine is much better. Here, temozolomide actually was slightly deleterious. This, by the way, is the mismatch repair deficient patient. And then there's another group here for whom lomustine is really the better drug, and the added addition of temozolomide really doesn't do much. And so 4 different subsets of patients. So to summarize this, we have a 4-fold variation in TMZ and lomustine response. And temozolomide is harmful for a few patients. Why we don't pay much more attention to this is kind of a mystery to me, because lomustine works in this group, and first do no harm, right? That's the old idea. Lomustine may be better than temozolomide for some patients. It might even be superior in the general population, but this was only a couple hundred patients. 10% have this 100% efficacy. 10% really hardly any or zero. A third get a really substantial improvement. Another third get a tiny or smaller benefit, and you can wonder whether or not they really need that combination. And temozolomide added to lomustine might be deleterious for as many as 15% of patients. And so you come away from this kind of analysis thinking there's no one best strategy for everyone. Maybe biosimulation can connect the right treatment with the right patient. And if we're not doing this kind of signaling pathway analysis, we're really probably not able to make a correct decision for giving the optimal treatment to the patient. And so I think this kind of artificial intelligence tool to take a large amount of genomic information and integrate it is really going to be something that could make an important step forward for patients. So thanks a lot for listening to that, and happy to entertain any of your queries.
I think it's truly a fabulous talk, and one of the things that I think is so striking, maybe startling to the audience who are listening, Dr. Castro, is just that fourfold difference in response. Glioblastoma, unlike some things, for instance, if you have coronary artery disease, you've got hyperlipidemia, you've got other type, or epilepsy, we may have fairly rigorously defined treatment paradigms that produce generally similar responses to wide swaths of patients. But what you've shown there is just the widespread variation that can occur. And one of the interesting things which the audience may not know, and I'd be interested to hear your comments on, just the relative bioavailability of lomustine versus Temodar in patients. As I understand, lomustine gets across the blood-brain barrier very nicely. But what are your thoughts on that as in these patients? Are we seeing more of a therapeutic benefit because of the BBB penetration of this drug, do you think?
Yeah, the nitrosoureas are super lipophilic, and they go right through. Temozolomide is one of the best drugs we have in the whole armamentarium, but it is susceptible to a couple of drug resistance pumps, including ABCB1, the P glycoprotein, and I think the other one is ABCC5, which is not part of the blood-brain barrier. But there are things that have come and gone as far as blocking P glycoprotein over the years, and I've been terribly disappointed that the funding hasn't been there for those companies to come into neuro-oncology and really try and improve the delivery of these drugs. I think the new nanoparticle drugs really do seem to make a difference in getting across the blood-brain barrier. And temozolomide is probably no exception. We could do much better if we can block that P glycoprotein.
Yeah, it certainly is. You've demonstrated so well that we need to use the underlying genomics and bioinformatics and artificial intelligence approach to really appropriately guiding our treatment, because one size doesn't fit all. One response is certainly not a guarantee that others will have similar sort of response, especially with the heterogeneous disease states such as this.
Exactly right.
Yeah, Michael, I thought super fascinating talk. I mean, obviously the reason I reached out to you is how much I really enjoyed this and reading about it. My question to you is, we talk about the relevance of this, and obviously Jason and yourself have alluded to it, but in your clinical practice, are you using this now? Or, how easy is it to use this? Can you actually send tissue, or do you just send the report that you get? Yeah. Is it just based on MGMT methylation status? How are you getting this data?
Yeah, so the key is to get deep genomic sequencing. And so what's nice about CellWorks is if you give them 150 copy number variations, they can model all 1,500 genes that are up and down and kind of integrate all that information. And so I think, if you're going to do these small gene panels and have 3 mutations, we're really missing the elephant in the room. And that is that, all of the tumor suppressors that are missing from gene deletions and oncogenes that are up, maybe not a lot up, but enough to influence the biology. For the most part, our early precision medicine days have not embraced copy number. And so what I do is I get people sequenced at Tempus. Tempus gives me, a detailed map from base pair coordinates of which gene segments are missing and not. And CellWorks can model all of that stuff. And so, once you're getting comprehensive stuff, and I compare doing genomics without copy number to, kind of crossing the street looking in only one direction. There's so much information that's in the chromosome aberrations in cancer. Everybody at Dana-Farber, interestingly, gets a chromosome microarray from the Mayo Clinic. And it's a revelation every time you see one of those. And so what I do is I get that information, I send it over to CellWorks, and then they give me a report in about 2 or 3 days. And so I feel much better equipped to make treatment decisions.
So you've changed your practice based on this then? I mean, you will 100% kind of take into account the results and tailor a treatment plan based on these?
Absolutely. Let me, I did bring another case, just kind of an anecdote from my practice, because the one question people ask me is, well, can you use this for things besides temozolomide and CCNU?
That was my next question.
Yeah. The answer is, in fact, they have a drug library of 250 drugs now that they can biosimulate. And so here's a patient from my practice with refractory GBM, 52 years old, bad tumor, unmethylated, TERT mutated, PTEN loss. And he has this 12q amplification, which is about 10% of glioblastoma, by the way, with 10 copies of this segment that has CDK4 and MDM2, both oncogenes. And this was his presenting MRI. He was operated by Arifala at UCLA, had a good result. Some people want to know, was it really GBM? Yes, it really was. And he got standard therapy, relapsed at 8 months. And in general, we don't get much in the relapse setting. LOMUSTINE is about a 3% drug, and regorafenib, which is better, is 5%. And in the biosimulation at CellWorks, both of these were ineffective, less than 20%. And on the other hand, there are some things at the top of this histogram here which look quite interesting. The CDK4/6 inhibitors, leflunomide, which is a rheumatoid arthritis drug, attacks a protein called DHODH, which is in the pyrimidine pathway. And it turns out in PTEN deficient cancers, DHODH is a synthetic lethal partner, which makes leflunomide effective. And then there's another drug on here, nelfinavir, which actually is an AKT inhibitor. And when you have PTEN loss, then the PI3 kinase AKT pathway is upregulated. And so here's the schematic of this particular patient's tumor. You see PTEN is missing here. It leads to upregulation of this, which makes leflunomide sensationally active, because this pathway of producing pyrimidine bases for DNA is highly activated in this cancer. Nelfinavir is really hitting two things. It blocks AKT and also inhibits the proteasome. So the P53 that's being taken out by MDM2 increases. And then finally, we have the breast cancer drug, ABEMACICLIB, which blocks CDK4, where there's 10 copies of that. And so here's a kind of summary of how this all works. There are, references about all of that. And so here's what I gave him. A breast cancer drug, an HIV drug, and a rheumatoid arthritis drug. And this is what happened. He had a striking response, which lasted until 6 months. And, we'll see if anybody wants to publish this. I think it's interesting enough that, I'm hoping that somebody might take it up, although it's already been rejected by the JCO Precision Oncology, and it was, as you know, we can't get case reports published in Neuro-Oncology journals.
Yeah.
So,
this was a recurrent glioblastoma that you ran through, your process, basically this AI process, and got an additional 6 months on a completely experimental therapy, basically.
Exactly. Because once you see what's going on inside the tumor, it creates what I call the therapeutic imperative. You got to treat that, or the patient's going to die. Mm-hmm. And if you do it, if you do it, the tumor may collapse. And I think it's the difference between practicing with and without a blindfold. You know, the molecular blindfold where we really don't know what we're doing. We're just kind of trying the next drug and seeing if it works. You take off the blindfold and you can see the ball come into the bat. And, you know, maybe it's going to fly out, but, you know, you might get a home run out of it. I think at least in this case, we got on base.
Where was, you know, just to be, you know, a little devil's advocate, where was a drug like Avastin on that histogram? Something that people would standardly go to in this setting. Was it even on there at all, or?
Let me see if Avastin, I
didn't see it.
Avastin,
yeah.
It wasn't on the histogram. And, you know, frequently Avastin comes out as a non-responder in CellWorks, unless there's HIF1 alpha is upregulated by mTOR and by PI3 kinase.
Yeah.
But, you know, Avastin, as you remember, the controversy of getting it approved, you know, it didn't affect survival.
No.
It affects quality of life by getting rid of the edema. And so it is possible that VEGF is going to stimulate the tumor in an autocrine fashion. But, you know, whether it can overcome all of those other pathways in the tumor, usually the answer is no in the hands of CellWorks.
Well, an impressive response, and on that patient, it really just, I think, a potentially paradigm shifting approach with the management. It certainly is eye-opening, and I think will cause a lot of our viewers to rethink how we're considering adjuvant therapy in patients with glioblastoma. So thank you so much.
Thank you guys
absolutely.
for having me.
Impressive work, and we'll upload this to our YouTube channel.
Fantastic.
So
Definitely, Michael. Thanks for sticking with us. I know it was a couple weeks delay here, but really worth the wait. Fantastic presentation, very provocative, and thanks so much for joining us. We'll see you all next maybe 2 weeks. We got to see who's on for next week. So
great. All the best, you guys. Be well.
Take care. Bye-bye.
Take care. Bye-bye.